Just want to remind everybody this September is Women in Medicine Month, so it's still it's one thing that AMWA celebrates if somebody wants to go to their website and learn more about it. But today I'm excited to have a session that was organized by Ginger Duncan, who is right there. Ginger is also a pathologist and a friend, and she had this idea of a session on transgender issues, which seemed incredibly interesting, important. And so Ginger is going to introduce the session and the speakers, and then we'll go from there. Not everybody that's supposed to speak may be here yet, but they may be joining later, so we'll see. We'll see who is here, and we'll start as we can. Thank you, Ginger.
Hey, yes. Hi, I'm Ginger Duncan, Virginia Duncan, but my friends call me Ginger, so everyone can call me Ginger. I'm an assistant professor. I'm also in the Department of Pathology, as Morissa mentioned. And I've been here for about 3 years. Now I'm starting my 4th year. And I wanted to take just a few minutes before I introduce the speakers to kind of tell you about why I came to this and why I thought of it and wanted to organize or help organize this. My hope is that this will be a way to increase awareness, get as much information to as many people out there as possible about transgender issues. I feel like I see a lot out there at UAB and generally focusing on the LGB part of the LGBTQ plus and not as much on the rest of it, particularly transgender issues. And there really are unique challenges and misperceptions and misinformation out there. And so I wanted to do my small part to try to help fill that void. My special interest in this topic comes from the fact that I'm a parent of a transgender woman. She was a teen when she started this transitioning journey, but now she's 21, which is hard to believe. I'm sure that those of you with young adults or parents of young adults can relate to that. They grow up. So she's now at college at the University of Washington in Seattle. She's in her last quarter, so headed out truly fledging the nest. She chose to leave the South for a variety of reasons, and we are lucky as a family to have many privileged opportunities, and overall really a very supportive extended family with a few hiccups, but mostly supportive extended family. For us, the journey has been and continues to be an extended journey, and our relationships are still shifting and changing. We're all still learning and growing. As a parent, as a physician, as a member of a nuclear family and an extended family, and as a member of society, I know that I personally have learned so much in the last several years, and I'm still learning new things. I feel like I learn something new every day about this. And I feel that if our family, as really motivated parents and motivated her younger sibling and motivated extended family, can still have so much to learn, then I know that others must also. Society has come a long way, but we still have so far to go. And so I feel that that is really important to bring that awareness. So that's where I'm coming from. I am by no means an expert, but our lineup of speakers certainly is. So without further ado, I'd like to go ahead and introduce them. This will be a 2-part series. So today is the first half. And I'll kind of introduce each of the 4 speakers that we have. And if we're missing still 1 or 2, then hopefully they'll come and be able to join us. So Dr. Morissa Ladinsky, comes to us from Houston, Texas first, and through Johns Hopkins. She's had faculty positions at the Ohio State University / Nationwide Children's Hospital as well as Cincinnati Children's, and has extensive private practice experience. She has clinical, educational, and advocacy roles, as well as having established and co-led the UAB Pediatrics Gender Health Team with Dr. Abdullatif, and then also her department's Health Equity Scholar Initiative. Dr. Hussein Abdullatif is our director here of Pediatric Endocrinology. He came to us first from the University of Jordan, and then went on to Emory University Hospital Systems, where he did a second residency and a fellowship. And then also with Dr. Ladinsky co-leads the UAB Pediatrics Gender Health Team. Dr. Krishmita Siwakoti is an assistant professor here specializing in endocrinology. Coming to us initially from Nepal, actually, the BP Koirala, hopefully I'm pronouncing that right, Institute of Health Sciences, and then went to University of Tennessee Health Science Center for residency, and then Yale School of Medicine for fellowship, and then eventually came and joined us. And our fourth speaker is Brianna Patterson, who's the clinic coordinator at UAB Medicine's Gender Health Clinic. She works with patients to improve their health outcomes, increase their connections with providers, and reduce or eliminate barriers that transgender folks may experience. In 2018, she also wrote a guest blog post for the UAB Institutes for Human Rights blog called No More, No Less, Basic Human Rights or Transgender Rights, about her experience as a trans woman. And I highly recommend reading that blog post. It was very heartfelt and inspirational and brought tears to my eyes as I read it. So that's highly recommended. So thanks so much to all of our speakers and welcome, and let's get started.
So I guess Hussein will be the first one, right? Because Morissa is not here yet. I don't see her. Does anybody see it? No.
She did send me a note that she is held in clinic, and so hopefully she'll be able to join us a little later. But I can wear her hat.
Sounds good.
So thank you everybody for inviting me. And my pronouns are he, him, his. So my gender is male, and I'm honored to be speaking to an audience of mostly women at the like Women in Medicine symposium. One little correction: I am not the head of endocrinology at Children's Hospital and Pediatric Endocrinology. The head of Pediatric Endocrinology is another woman, Dr. Ambika Ashraf. So I will not want to take that from her.
Thank you for correcting that.
Oh, that's fine. I'm a core clerkship director, so I am involved with medical student education as well. And what Morissa and I were planning to speak is something relatively brief, which is, since we're the beginning people, is that, and you did bring it up, Ginger, there's the LGBT issues. And so there are three domains that sometimes are interacting, but not necessarily all of them the same. And so that's kind of important for us when we are talking to families and children, who are coming with gender identity questions. And the three domains are gender roles, which is kind of how we act, how we behave, what clothing we wear, what kind of, like, do we put fingernail polish or wear things that are pinkish or bluish or God knows what, or do we play with dolls, or do we play with trucks, or do we mix it up? So that's all what we call gender role. And gender roles do not necessarily have to stick with the gender, the sex that we were born in, and they do not have to correspond with our gender identity or with our sexual orientation. And the second thing is the issue of sexual orientation, and that's kind of related to the LGB not T yet thing, is that's kind of lesbian and gay and bisexual issues, and that's who we are attracted to sexually. not necessarily who we identify ourselves as being. And that's another separate domain. And the third domain is the issue of gender identity. And gender identity, we define it as who we are and what we feel like inside us. So I just noticed that Morissa had just joined us.
Good.
Morissa, you can take over and correct anything I say, because you're much better spoken than I am.
Oh, you got it. You got it, friend. Sorry, I was held up in primary care clinic. No, I think Hussein's got those, those key definitions laid out. That gender identity, who we know ourselves to be from the inside, that internal sense is laid down, is understood much earlier in child development, anywhere from 3 to 5 years. Kids know who they are from a sense of gender. But if that gender that they are growing and knowing themselves to be does not align with their sex assigned at birth, the interesting part is we clinically meet these kids and begin to, as they find words to express it, and it's closer to puberty. It's the onset of puberty or just before, when the largest variety of the youth we care for are finding words to understand that their sense of internal gender does not match their sex assigned at birth. Sexual orientation, who we're attracted to, is a completely different entity. It's a different trait. In healthcare, we really conceptualize them as 2 traits of a person. Nobody made somebody gay. Nobody made somebody trans. They're traits. But sexual orientation, who we're attracted to, that really fills in child development later, around 10 to 12. So that's just sort of setting the stage in the background. The other thing that we feel is that there are not more gender diverse or transgender people in today's America than there was 30, 40, 50 years ago. It's the visibility for gender diverse people and for people who hold gender diverse identities. I had some fun slides, but youth, people find those words. And yes, maybe it was Caitlyn Jenner's very, very, very public transition that gave so many people in our nation words to express what they had been grappling with and feeling for a long, long time. But for today's youth, there's so much visibility around trans and gender diverse identities, and role models are everywhere. In Senate hearing rooms, in the confirmation of, we boast because we have a pediatrician as the number 2 at Health and at Department of HHS, but Dr. Rachel Levine just happens to be transgender. There are people all through that hold public office all over the place, and in classrooms you have teachers as well as students. So transgender people have role models everywhere. And with that, keep on going. I'm turning it back to you, the best partner anyone could ever have.
Oh, shut up. It's like, I'm saying shut up in front of a big meeting. That's inappropriate.
That means so cool.
So we are, as pediatric endocrinologists and pediatric adolescent and generalists, what we do in our clinics when we are taking care of kids who are gender diverse, we, of course, because what pediatrics is from birth until the age of 21 by definition. And so we have patients that come to us at different stages of life at different ages. And therefore, the expectations of our management are different depending on where they are in their age and in their puberty stage. And so when they come to us, when kids come to us with their families and they are not yet in puberty, our main role is hand-holding, supporting, acknowledging, and humbly listening to them and their concerns, and see how we can help them how we can help them with their bigger support system, perhaps finding an alternative support system within more accepting community. And we do have in our clinic a very close relationship with our chaplains who will be available to help families if they are dealing with religious conflicts, religious worries, religious anxieties of some sort. When a child enters puberty, and if they come to us at this stage just as they're entering puberty, then our aim is to stop puberty. So that's when we use puberty blockers in order to put everything on hold in puberty. And with that, we achieve two very important goals. One of them would be to buy more time to allow the child and the family mature in the gender identity that they are in, whether it persists or it desists, meaning they go back to the sex that they were born in. But also, if they persist in that gender identity, then when they reach the age at which time they will receive the hormone affirming therapy, then they would be ready to receive it without having to deal with removing some of the changes that happened in the body that they may not desire. You know, for example, breast growth, if you're a female to male transgender person, you don't want that, it's more difficult to reverse it, or facial hair if you're a male to female transgender person. So that's kind of what we do by putting kids that come to us before puberty or as they enter into puberty or in the beginnings of puberty. Now, when they come to us at the end of puberty or puberty has completed, which is probably the majority of the kids that come to see us, then it becomes a different role, which is one, how can we help them immediately? And what does that mean, helping them immediately? One of them is affirming who they are, supporting who they are, finding if they do have any support related to psychologists, mental health support that they need, but also can we do something right away that can help them with some of their dysphoria, and before we start them on hormonal therapy that affirms their gender. So for example, oftentimes when we see someone who is a trans male, one of the reasons for their gender dysphoria would be menstrual cycles. And we can stop menstrual cycles by using either intrauterine devices or using progesterone only birth control, forms of birth control that can stop the menstrual cycle. So we can get them something that can help relieve some of their dysphoria as we're processing and together going through the process of eventually deciding to start on testosterone therapy. And same thing for someone who's a trans female, then we do want to try to give them some forms of anti-androgens that help minimize some of the effects of the androgens on their body and give them some form of relief and happiness about some little changes that are happening as we are getting towards fulfilling the requirements that they need to fulfill to receive testosterone or estrogen therapy, depending on the child. So that's basically what we do in pediatrics. It's each patient that comes to us is unique with unique needs, which I'm pretty sure that Krishmita has the same kind of questions, but part of what plays a role is where they are in puberty and at what age they are. And the other one is that they're not independent. They come from families, and families are oftentimes the decision makers. So we are working with families to support them make the wisest decision that they can make and open their minds if they are hesitant. That's us.
That is us. And it's important to know that this is us. And our youth are incredible, incredible kids. The Alabama, as you well know, is one of the 10 states that was really pinpointed in the last session with state level legislation that would criminalize the prescribing of puberty blocking medication and or gender affirming hormonal therapy to minors irrespective of parental consent. And we will again face that in the legislature, but it's very important to know that there is this is a journey. Youth never come to our clinic and walk out with a prescription for hormones. It's a longitudinal journey where we are there as a team, supporting them and their families. The decision to begin hormonal therapy is made by all of us together. The team, the parents, the family, and their mental health provider. The kids they're not driving this bus by themselves. So you'll hear a lot more misinformation as we get into the 2022 legislative session. So it's just important to know that. And thanks for your continual support. Is Krishmita
Back to you.
You're muted.
Nope.
Hi everyone. So I guess next would be my session. I have created a small PowerPoint, if that's okay. I'll start sharing that. Oops, I'm not able to share that. I'll just
Jessica should be able to let you share. Right, Jessica? I sent an email to Brianna. I haven't heard back. I don't know if any of you has access to her.
So last time when I talked to her, she was planning to join this meeting, so I can text her really quickly.
Okay.
All right, can everyone see my screen?
Yep.
Yes.
Mm-hmm.
So thank you for this wonderful opportunity. I am the endocrinologist at UAB. I have been here for 2 years, and I'm also the director of UAB Gender Health Clinic that we established just over a year ago. We started it in September of 2020. And so far, we have grown quite a bit. We have 200 plus new patients in last 1 year. So, we are really happy that it's growing well. So I will be mostly talking about, transgender care in adults. So I have no conflicts of interest or disclosure. So I'll be mostly talking about the basic procedure for hormone transitioning, risks and benefits of hormones and or surgery, and then a little bit of touch on preventative medicine. So what is transitioning? So there are two major goals of hormone therapy. So the one is to reduce endogenous sex hormone levels and thus to reduce the secondary sex characteristics of the individual designated gender, because most of the time in transgender or gender non-conforming individual, that is the reason of their dysphoria. And then to replace the endogenous sex hormones consistent with their gender identity, just to help them get rid of the dysphoria. So usually whenever a patient comes to my clinic, I usually confirm gender dysphoria just based on history. What are the features that are causing them dysphoria? What are the expectations from hormone therapy? How long have they been feeling that way? And most of the patient, as long as they can remember, they have been feeling about their gender the way they are feeling now. So it usually goes up into childhood, or even though they didn't know the word transgender until they were in teenage or adults, they still had some kind of knowledge about their gender identity from the very beginning. And then we usually evaluate and address medical conditions. This is by history. I also do a set of labs to make sure they don't have any big medical issue that will prevent them from starting hormones. And usually these are young, healthy patients, so there are rarely any contraindications to starting hormone in these patients. And then measure hormone level during treatment, not to undertreat or overtreat them. And then also education is very important. When they come to the clinic, they have been waiting, especially when they come to my clinic, they have already been waiting for this so long. They have waited almost their whole life until then to start the hormones. So they are like, things are not already happening fast enough. So we need to educate them about the onset and time course. I usually tell them it is like going through second puberty, because things are slower. The first 6 months, you may not even see changes, and it takes 2 to 5 years to see the full transition, just so that they know what to expect, and they are still compliant with the therapy and not distressed just because they are not seeing any changes within a couple of weeks or months. And then touching on the gender hormone therapy, let's start with transgender men. Testosterone is the mainstay of hormone therapy, and we usually use either parenteral, which is IM or sub-Q, or transdermal, which is the testosterone gel. Usually with both, the transition is similar, and I start with the standard dose based on what patients' expectations are in terms of transition, and then titrate based on how they feel clinically in terms of transition, whether they are happy or not, and also based on their labs to see what their levels are. Usually with both, the transition is pretty similar. Sometimes it's a little bit slower to get the hormone levels with the transdermal form, but it's not really clinically significant, because in the first 3 to 6 months, you don't see much changes with either. So it's mostly patient preference for me. And we don't have any major society giving guidelines for transgender care. So most of the things I present are also from my own experience, and also some anecdotal evidence from my patients. And then, so talking about masculinizing effects, so these are so I usually talk to patients when they come to me, what are their expectations, what are the things that they are expecting from the hormones. So, and then, based on that, I counsel them. Usually it takes 6 months, to see most of the changes, even like, skin oiliness, acne, they can see even within first few months, and some fat redistribution. Sometimes there can be cessation of menses within 3 months, but sometimes it may take longer. And just like Dr. Abdullatif said, we have other ways to make sure they don't, and most of the patients, when they come to me, they either already have IUD by their OB, or they are already on progesterone therapy. And then most of the changes, it starts at 6 months and takes, sometimes up to 5 years to have the full effect. And things like deepening of voice and facial hair, body hair, those are irreversible. So I talk to the patient from the very start that, these are irreversible. So they have to be sure that they want the transition. But by the time, from my experience, by the time most of them come to me, they are already ready and prepared for the transition. And then these are some of the examples of hormones, what the testosterone does. So we can see that there could be facial hair, some muscle build, depending on, it also depends on what type of workout they do. Definitely voice changes, some clitoromegaly, which is also called bottom growth, and definitely cessation of menses past 6 months. So this is another transition over time. This takes up to 5 to 6 years to have the full transition. And then when I talk to them about the hormone transition, I also personally tell them about the risk associated with the transition. And these are, like I said, young, healthy patients. So the risks are very rare as long as they are taking the right amount of prescribed dose and not taking anything from outside. And then we are monitoring them closely. So very high risk of erythrocytosis with testosterone. And that increases the risk of DVT. So I counsel them about that. And I also counsel them about coronary artery disease, severe liver dysfunction, hypertension, breast or uterine cancer. And the evidence are, not very strong for any of them, but I always counsel them about healthy diet, lifestyle, make sure they are taking the right dose, and then monitoring also closely. So I'll talk about the monitoring. So the first year I start them on transition, I usually like to see them every 3 months to see any, signs of viralizations, and also if they have any adverse reactions, and also check their levels to keep them at the target goal, which is 400 to 700. And usually I like to check the mid-level dose for the testosterone. But sometimes if that's not possible, I also either do the beginning or end of the dose. And that is mostly for injections. Gel are every day, so it doesn't really matter when you check the levels, as long as It's after 1 week of daily application. And then I also monitor their hematocrit every 3 months. Same thing for weight, blood pressure, lipids, screening for osteoporosis, especially if they have been on testosterone for a while and stop it, or they are not compliant with therapy, because you need either testosterone or estrogen for bone health. And they will develop a bone loss if they are not compliant or if they stop after a while. So usually I tell them until the age of 50, make sure you are taking, and after that it's individual choice whether they want to reduce the dose or stop the testosterone. If the cervical tissue is present, monitoring by pap smear as recommended by American College of OBGYN. If they have had total hysterectomy, then they don't need that. Ovarectomy can be considered after completion of hormone transition, and mastectomy if they still have breast tissue. But if mastectomy has been performed, then sub or periolar annual breast exam to make sure they don't have any nodules or breast nodules. And then let's talk about transgender women. The hormone transition in transgender women is a little bit more complex because we need estrogen as well as an androgen blocker until the testosterone continues to be below the range where we want. And also sometimes with estrogen, there are certain things that the estrogen is not able to do, so they need other kind of treatment also. So when it comes to estrogen, I usually start with either oral or transdermal. I like transdermal because of better side effect profile, especially for the risk of venous thromboembolism. I use parenteral estrogen in patients who are not able to reach their goal with oral or transdermal preparation, because we don't have a lot of data on parenteral estrogen, especially for long-term use. And then in terms of progesterone, so I bring this up because a lot of patients ask about progesterone also. The societies, couple of societies that we have, they don't recommend progesterone for the transition because we don't have any strong evidence that shows progesterone helps with any of the transitional changes. But all the studies are smaller, and I don't think we have good enough data. So whenever patient asks for progesterone, it's usually anecdotal. Some people who are on progesterone, these trans women report that they feel like the breasts are fuller on progesterone, so they don't want to stop it. So, but I do warn them about the slightly increased risk of cardiovascular disease and breast cancer when they are on progesterone. Some patients ask about topical. Some of the physicians I've seen also compound for patient to apply locally, like facial, or breast, around their breast. It is quite expensive, and there is no evidence at all for the topical, so I don't usually prescribe that. And then blockers are the second, these are something that start more sooner as compared to estrogen. So in order to help with some of the dysphoric features like facial hair, some people have dysphoria even with erectile function, so it helps with that. Spironolactone is the most common androgen blocker that we use. It works by blocking androgens, working with their androgen receptor. Cyproterone acetate is a progesterone compound with anti-androgenic property. It's used very widely in Europe, but it's not approved for use in America. And very rarely, usually the GnR is agonist, but these are expensive and most of the time not covered by insurance. And most people, instead of doing injections, they prefer pills. So I usually go with spironolactone. And then in people, they are, who cannot tolerate spironolactone, there are a couple of other options which we discuss on case-to-case basis. And then same thing for feminizing effects with estrogen. Most of the effects are seen after 6 months. So again, counseling and setting expectation is very important. And there are things that estrogen does, like redistribution of body fat, decrease in muscle mass, some decrease in libido that I always counsel about, and decrease spontaneous erections, breast growth, and then decrease in terminal hair growth, but it usually starts after 6 months just because of the life cycle of the hair follicle. And then unfortunately, the testosterone does not cause much voice changes. So usually treatment by speech pathologists for voice training is most effective. But in my experience, a lot of patients are also watching YouTube videos and have started practicing high-pitched voice. And after a few months, they do really well with the voice function. And I counsel them that, decrease of terminal hair can be achieved by estrogen, but it doesn't take it away completely. So most people, after a couple of years, they end up getting laser or electrolysis. And then, so these are some of the, usually after 4 to 5 years, they have changes in their body composition, breast development, loss of facial hair, not completely, depending on what they are doing other than just the hormone therapy, and voice, depending on where they are working with speech pathologists, working on their own. And then same thing with estrogen. We also talk about the adverse effects, mostly with thromboembolic disease, especially in smoking patients. I always counsel them. I start with a very small dose of transdermal and always counsel them. If they don't quit smoking, then I won't be able to go much higher on their estrogen dose, so they may not have full feminization effect. So I usually give them a few months to work on stopping smoking, and then after that we can go up if they need it. And then also counsel them about macroprolactinoma, which is very rare, breast cancer, hypertriglyceridemia, cholelithiasis, and also some history of CAD just because of increase in hypertriglycerides, increased insulin resistance, so just eating healthy, maintaining a healthy body weight, etc. And same thing for monitoring as in transgender men. First 3 months, first year I see them every 3 months, and then 1 to 2 years, depending on their feminization, and also, if they have achieved their goals. Usually the serum testosterone, the goal is to keep it below 50, and then estradiol between 100 to 200. And sometimes on patients who are on injection, it goes above 200 very easily. But as long as it's not unreasonable, like, still below 300, I let it go above a little bit above 200. And I haven't seen any adverse effects so far. But again, we don't have enough patients to tell that for sure. So I always counsel them that, we can't go much up on the dose. And then again, if they are on spironolactone, potassium every 3 months, and then annually then after. And then routine cancer screening, especially if they have the organs, then they need the cancer screening. And same thing for BMD, bone mineral density testing. Those who are not compliant with hormone therapy, or they stop after a while. If they are a low risk, then 60 years and above is we can start the osteoporosis screening. And so next step, once they have had the hormone therapy, is the surgery for sex reassignment. Especially genital sex reassignment surgery. So only after mental health provider and endocrinologist both agree that surgery is medically necessary and would benefit patients' overall health or well-being, because hormone therapy, there are some irreversible changes, but most changes are still reversible, but surgery is completely irreversible, hence. So major guidelines recommend completion of at least 1 year of consistent and compliant hormone treatment, unless hormone therapy is not desired or medically contraindicated. But usually, in my experience, most surgeons do 1 year of consistent hormone therapy. And then there is a medical clearance required from endocrinologist or a primary care doctor along with mental health provider. So usually, I refer my hormone-treated patients for genital surgery when they had a satisfactory social role change. They are satisfied about the hormonal effect and happy with their transition so far, and they tell me that they desire definitive surgical changes at that point. And then, so Dr. Abdullatif or Dr. Ladinsky might be able to tell me this, or confirm this, but from what I have read, for pediatric patients, or there is recommendation to delay gender-affirming genital surgery, which involves either gonadectomy or hysterectomy until patient is at least 18 or at least legal age. And then timing of breast surgery for transgender men is based on physical and mental status. There is no timeline that is recommended for breast surgery. And various surgeries that are done, especially in transgender men, are metoidioplasty, which is working with the existing genital tissue to form what is called a neophallus. And this is preferred because of the the innervation And this is a little bit more functional without requiring a lot more devices. So this is what is preferred by most surgeons. Phalloplasty is a construction or reconstruction of a new penis. So we usually metidoplasty, they work with the genital tissue that's already present. For phalloplasty, they take tissue from a completely different site, and then nerve innervation, and sometimes devices are required to inflate and deflate the neopenis. And then top surgery for men, which is bilateral mastectomy. And vaginoplasty is a creation of neovagina using the penile tissue. And this is slightly less complicated than surgery for transgender men. So more and more women are, transgender women are seeking the vaginoplasty or bottom surgery as compared to transgender men. And there are various other cosmetic surgeries, especially for transgender women. And these are usually not covered by insurance, which are facial feminization surgery, which is done by plastics, voice feminization, which is done by ENT, breast augmentation, tracheal shape, buttock augmentation, orchiectomy, etc. And just to let everyone know about the UAB Gender Health Clinic, it is one of the few centers in southeastern US, which is a comprehensive interdisciplinary approach to both medical and surgical management of gender health. We are located at Whitaker Clinic at UAB, and I am there every Friday between 8 to 12. Surgeons come there once a month. Infectious disease, the Dr. Van Gerwen, she comes there twice a month. And then we also have voice therapy, internal medicine, psychology, but they are not on site, but we refer our patients to them. So we usually provide hormone therapy, psychological evaluation and management, voice therapy, top and bottom surgery. And if anybody is interested, fellow resident, medical student, then they can contact me. And Brianna Patterson, she's the program director of our clinic, so she can be contacted as well. So, so this is the logo that was made by Brianna for our transgender clinic. And this was the picture we took on the first day of our clinic. So this is me, this is Brianna, and this is Dr. Patrick Soff, who is the urologist who provides gender-affirming genital surgery. So with this, I would like to conclude my presentation. These are some of the guidelines that I use for treating transgender patients. And that's it for me. Thank you so much.
Thank you so much. And I see we have Brianna Patterson with us now. Brianna, do you have a camera? Are you there?
Yes, I'm here. I do have a camera. I'm just trying to pull up. I don't really have much to add to Dr. Siwakoti's, other than the fact from a patient's point of view, I can provide a little bit of the trans experience. And for me, just as a background, I did serve in the military for several years, and then after that into the fire service for 23 years. So I do kind of break the stereotype in a lot of different ways. If we have time, I'll do a brief, I'm gonna switch over to my laptop and try to do a brief presentation. I just have one slide, if that's okay. Awesome.
Yes, absolutely.
Okay, can you? Could anyone let me be able to share my screen real quick?
Jessica should be able to do it, Brianna. Jessica is in charge.
So I'm just going to share this really, really quick and get to the one slide that I want to provide. Just let me know if you can hear the sound okay as it comes up.
We're not currently hearing any sound with it.
What it was like to be
Oh, now we do.
unseen. I had to hide from my grandparents, mom, classmates, everyone. I did not have a name, term, or understanding of who or what I was, but I knew I was different. I liked and was drawn to things that were reserved for girls. That beautiful Christmas maiden doll, so cute with curly hair, bright clothes. I remember the devastation I felt when I was told that I could not have that doll. I began a lifetime of withholding my true self. I started to do any masculine activity I could all through school. I rode BMX bikes, skateboarding, played football. I joined the Marine Corps when I was 17. I went through one of the toughest training programs at Parris Island because I learned at a very young age and was drawn to things that I do apologize because I wanted the world to be proud of me. And as a Marine, I was one of the few, the proud. But nothing was heroic enough or masculine enough to change who I was. I pursued more intense training as a sniper, which teaches men many things like hiding, a primary lesson for the sniper. It fit right in with my hiding my true self. Even when I left the Marine Corps, I still needed to be the bravest. I became a fire medic, became an expert in hazmat, confined space, and rope rescue, even recovering bodies in dark, dangerous waters. All to prove I was something that I was not. I had finally found a name for myself. I realized that I am transgender. When my fellow first responders found out, they decided to make sure I was manly enough to do the job. I was sent into a fire room alone to battle a blaze. I was supposed to feel the heat. I ended up with second and third degree burns, but then forced to take a day off without pay. After 2 decades of working in public safety, I reached a breaking point. I could no longer live every day as something I was not. I had 2 choices: transition into my authentic self and perhaps lose everything, or plan and finally carry out a suicide that would let me leave humanity affecting the least amount of people. I started by changing my name. By the time I was 36, I was diagnosed with lung disease, took multiple daily medications, had recovered from 16 broken bones, 200 sutures, and multiple surgeries. I lost primary care providers because either they couldn't care for me or refused to care for me. I did lose everything I had worked so hard to create. No more fire department, no more male privilege, no more security about the future and access to better health. At this point, I am not whole, but I am on my way to being the best version of myself. To this day, I do not recall what happened to make me choose life over death, but I am working every day to create a positive social change for my community, to help others find their true identity, access safe healthcare, and advocate for inclusion. Okay, that's really the basis of my presentation. It's just, as a patient, I have been refused care or fired as a patient 9 times by 9 separate doctors. And that's for physical health. Mental health, I've actually been refused care only 4 times. So, and it was mainly just due to religious aspects. For some of them, they just didn't have an idea how to treat trans individuals and didn't really want to learn. And the other part is just, I don't know, I can't answer for them. So, but yeah, I'm also an individual that's willing to answer any questions pertaining to the trans population or my trans experience. But I do put this caveat: if it is inappropriate, then I will let you know. I'll still probably answer the question, but I'll let you know that it's inappropriate and never to ask that question ever again, type thing. So with that, if there is any questions or anything else I can elaborate on.
Thank you so much for that, Brianna. That was amazing. And thank you to our other speakers as well. We do have time for questions, so I open the floor.
There's a question in the chat from Jody about what's the best way for us to help advocate for trans children and adults in light of the bills advanced in Alabama?
And probably the best person to answer it would be Morissa, if she's, I think she may be still.
Oh, I'm right here. Thank you so much. So, you know, around the country, it's pretty common knowledge and it's pretty well known that really only about 25% at the most of the American population has ever really known a trans or non-binary or gender diverse youth to really to have seen firsthand their story, their journey. You may be a friend of their parents, you may be that child's friend's parents, but overall about 75% of Americans really have no firsthand contact with transgender youth. So they're a small part of an already marginalized population and one that can't fight back at the ballot box. So the important thing is just knowing misinformation where it is, understanding that trans kids are simply kids and trans teens are simply teens. So if you hear conversations, to, you know, as a physician, people listen, and to just underscore that this is evidence-based standard of care medicine and has been for close to 20 years. That said, if anyone does reside in the Trussville area, Senator Shea Shelnut is the now third-year sponsor of the Senate version of the bill, which has already been pre-filed for 2022 as Senate Bill 5. Do not hesitate to reach out to or to write to your elected officials in the Alabama legislature and, you know, advocate as a physician to, you know, the amount of legislative overreach into the domain of healthcare decision-making, especially when it involves the relationship between a doctor and a parent, is one that should stand sacred. We hope that it's a, you know, pretty quick legislative session around this bill. Our friends in Texas will have a much more difficult challenge with what's coming up there. But I think that's how you can advocate, you know, visibility, talking, understanding, asking. And as I've said, if you do reside in the Trussville area, Senator Shea Shelnut is your state senator, and he is the sponsor of this bill. And our friends in Trussville and around that area are the ones that guarantee his paycheck. So, thanks. Yeah, what else?
I have a quick question. So as a parent, one of the things that I have heard from both of my kids, actually, first from my oldest, but also something that my youngest has been experiencing through school, is that some of their friends don't have the parental support. They don't have that community and emotional support. And what some of them turn to are kind of DIY therapies, and I'm wondering what your experience has been with that and how many kids you see come to you like that, and what that experience is.
Well, Dr. Latif's had that firsthand in the days before our clinic was a formal initiative. So I'm gonna let him share that with you.
Well, it's kind of like, this is a really very important and very good question. Because we are pediatricians, so we are seeing patients that are coming with their parents, or not necessarily with their parents' support, but with their parents' concern, let's say, So that's great in a sense. Like one of my first patients to see was a patient who the mother was not supportive necessarily to start medications or do gender affirming therapy, but the child started buying medications online, and that caused the panic to the mother. And basically they decided, the mother and the father, that I'd rather have a physician follow rather than them buying online. So the threat, in a sense, to a parent of your child maybe buying things online coming from God knows where, versus having some kind of a controlled environment where we are doing it safely, may help some parents, may help persuade some parents that really we need to come to a clinic like this. We do have some of our, not really our patients, but we've had some contact with patients, not patients, with human beings, with children who are trans, who do not have supportive parents, and they start communicating more with our social workers, trying to find what is a path for them to go. One of them was actually very successful, that the child made a case of changing who their legal guardian is, and ended up coming to the clinic because of the child's advocacy. So some of the online resources are really good, important online resources. The question is kind of, they need someone to help them and support them and guide them. And the good news is that some hesitant parents and guardians do come to see us, which I always find as a positive sign that they actually are coming rather than not coming. The hardest ones are the ones where the family is completely closed.
Unfortunately, and one thing that as a parent you can help your kids advocate with their own friends if they're in the situation that Dr. Duncan brought up, is in the Birmingham area, we have the Magic City Acceptance Center, MCAC, which is a youth drop-in and support center. Most of their programming now is online, which is great because they can reach a larger audience. But there they are in a online space, and soon hopefully a physical space, with a lot of other youth who are really walking in the same shoes as them, and under the guidance of very, very excellent professional, well-trained youth leaders. The Mobile area has a similar group called Prism United. The Montgomery area has Montgomery Pride, which is a drop-in type youth center as well, and Huntsville does too. So around the state, youth can also find solidarity, validity, and sometimes safety through, we really do have an impressive network of resources for gender diverse and LGBT youth in our state.
What other questions?
The one other thing that I don't know, at least with youth, of course, but for Krishmita and Brianna, it's also important to know that not all transgender adults really see gender affirming surgery as a need or as part of the path and journey to affirm them in their identity. Surgery is something that people are always just, so inquisitive about, but it's really not a universal. So I think that's important to know.
Right, yes. Most adults who come to me are just, wanting hormone transition, and most of them do want mastectomy or breast augmentation, but for gender affirming genital surgery, most of them don't want it right away, especially at the beginning, because for once, they are not sure whether insurance is covered. It's very complicated, especially for trans men. It's a multi-step surgery, a lot of, downtime. It takes years to recover. So most of the adults also don't end up getting surgery. They usually just do hormone. And sometimes patients, they come, they talk to us, and then they also choose just the route of doing social transitioning and not going with hormone therapy either, which is fine. We just let them make the decision, and if they want a surgery or hormone, we just help them achieve the goal.
Well, on behalf of AMWA, I want to thank everybody for a wonderful session. Ginger for the idea and the organization, and all the speakers. You're very inspiring, and we would love to help in whatever we could to bring more awareness and advocate for these individuals that by all means deserve all the respect and in our efforts. So thank you, everybody. And our next session skips October because we already have another speaker for October, but November 16th is another Tuesday where we'll have a second part of this discussion with other speakers, including what we're doing at the medical school to teach medical students how to take care of individuals, transgender individuals. So thank you, everybody, so much. Thank you, Brianna, for joining us from the car. Your video was amazing. Bye, everybody.
Bye, everyone.